eMedica for renal cardio care. 4-program scientific framework. Core modality. eMedica applies low-level voltage current frequency (VCF) microcurrent to targeted tissues. At microamp intensities, electrical stimulation has been shown to raise cellular ATP and protein synthesis and to modulate blood flow/vascular tone. Mechanisms relevant to erythropoiesis support, nephron energetics, dialysis tolerance, and blood pressure regulation. eMedica is adjunctive and must sit on top of guideline care, KDIGO. It does not replace medications, dialysis, or procedures. Program 1, Anemia, CKD related. Goals: support oxygen delivery and fatigue symptoms by improving microcirculation and cellular energy in marrow and peripheral tissues, while patients receive standard care. Iron repletion, ESA, when indicated. Mechanistic rationale: microcurrent ATP/transport in target tissues supports energy-hungry steps of hematopoiesis and peripheral oxygen use. Frequency patterns aimed at endothelial NO bioavailability and regional flow to enhance tissue perfusion. What it is not. eMedica does not substitute for iron/ESA decisions, which follow KDIGO thresholds and safety monitoring. Program 2, Kidney failure, elevated creatinine, CKD. Goals: support residual nephron function and systemic clearance. Help symptoms, fatigue, cramps. While standard drivers, BP, glycemia, RAAS blockade, avoidance of nephrotoxins are managed per guideline. Mechanistic rationale: voltage/microcurrent to renal region arrow helps restore membrane potential and ATP-dependent transport, supporting tubular handling and microvascular perfusion. Physiology-based adjunct. Frequencies targeting inflammation/vascular tone may secondarily ease intrarenal hemodynamics. Hypothesis-driven adjunct. Limits: effect is modest in advanced fibrotic CKD/ESRD, low nephron reserve. Strict adherence to medical therapy remains primary. Program 3, renal dialysis, hemodialysis, or peritoneal dialysis. Goals: improve intradialytic comfort, cramps, hypertension, support interdialytic perfusion, and aid tissue energetics. Align with individualized fluid and electrolyte prescriptions. Mechanistic rationale: low-level stimulation can modulate autonomic tone/vascular caliber and blood flow velocity, potentially easing cramps/orthostatic swings adjunct. Fluid guidance by renal team. Common clinical rules of thumb exist, e.g., HD approximately 500 milliliters plus previous 24-hour urine, PD approximately 750 milliliters plus urine. But modern programs individualize by body size, dialysis dose, interdialytic weight gain, and comorbidity. Always follow the unit's prescription. Program 4, hypertension without CKD. Goals: complement antihypertensive therapy by supporting endothelial function and autonomic balance. Reduce vascular resistance. Standard BP targets and drug choices follow KDIGO/HTN guidelines. Mechanistic rationale: electrical neuromodulation, e.g., TENS/electrostimulation paradigms, can increase NO metabolites and influence sympathetic activity, aligning with the biology of BP control. Used adjunctively to meds. Why results differ and the main limitations. Disease stage and substrate. Earlier CKD/less vascular remodeling, more room for physiologic improvement. Heavy fibrosis/ESRD, limited effect. Etiology and comorbidities. Diabetes, autoimmune disease, and heart failure alter response. Program adherence and dose. Consistent sessions, correct placement, and adequate hydration matter. Medication stewardship. Nephrotoxic or excessive meds can negate gains. Safety, meds, diet, and fluids carry over from your earlier brief. Medication caution, mandatory. Use only clinically required drugs at the lowest effective dose. Avoid self-medication and NSAIDs unless approved. Excess chemical load can worsen renal function. Coordinate every change with the treating clinician. Diet, renal. Limit sodium, manage protein, usually moderate or restricted per CKD stage. In later CKD, restrict potassium/phosphorus as prescribed. Prefer fresh, minimally processed foods. Pairs with BP control and anemia management in KDIGO. Fluids. Do not self-load water. Fluid allowance is individualized. On dialysis, follow the unit's rule, often a urine output-based allowance, adjusted for size and prescription. What to measure to prove value? Anemia. HB, ferritin, TSAT, ESA/iron dose requirements. Fatigue scales. Kidney failure. EGFR/creatinine trend, albuminuria, BP, symptoms. Dialysis, interdialytic weight gain, intradialytic hypertension, cramps frequency, post-dialysis recovery time, hypertension, home ambulatory BP, antihypertensive dose burden, markers of endothelial function where available. Evidence anchors for the biophysics plus guidelines. Microcurrent, increased ATP/protein synthesis at microAMP range. Electrical stimulation, changes in blood flow velocity/vessel caliber. Hypertension, neuromodulation, TENS/EA, increased nitric oxide metabolites/adjunct BP effects. KDIGO, guidance for BP in CKD and anemia care iron ESA. eMedica, microcurrent that energizes cells, improves flow, and complements KDIGO grade care across anemia, kidney failure, dialysis, and hypertension.